Good evening, everyone, and welcome to today's wonderful evening with Dr. Murali Bharadwaj. After a long break, because for the past 2 months I had been quite engrossed in the clinical work, morning 9 a.m. to 10 p.m. in the night, patients after patients. So even now, I'm broadcasting sitting in the TX hospital in Hyderabad. So the whole idea is every day we meet, we study together, and one day conquer the dream of clearing the postgraduate entrance. And of course, now the final year exam has become NExT, and NExT is really, really tough nut to crack. Unlike earlier days where we used to say, if a short notes was given about ranula, we were saying ranula was a cannula and still pass surgery exam. But now it is not like that. We need to be very, very specific in answering a MCQ-based exam in the NExT. So let us make the great beginning, doctor. Can you please punch whether the voice is loud and clear? Can you please punch? Is voice loud and clear? Everybody? Yeah. Can you please punch so that I'll know that the broadcast is good? Yeah. Please give me a feedback. Is the voice loud and clear for all of you? So let's make the great beginning, doctor. Yes. Abnormal wound healing. Keloid and hypertrophied scar. They both are the manifestations of the abnormal wound healing. Both are refractory to treatment. And what is the treatment? It is the triamcinolone is what you need to remember. The triamcinolone injection, silicone gel sheeting, and laser. Today, when you become dermatologist arena is the keloid and hypertrophied scar management. So this is what we call keloid. This is an example of hypertrophied scar. Now, one of the favorite questions of the examiner is, what are the differences between a hypertrophic scar and the keloid? Hypertrophic scar does not spread beyond the boundary of the original incision. And hypertrophic scar develops soon after the surgery. Over a period of time, there is an improvement. And it results, if you do surgery, the results are very good if it is a hypertrophic scar. Whereas keloid, there is a genetic predisposition and it extends beyond the original incision and it develops months after the trauma. And what are the classical sites of keloid, doctor? Or the earlobe, shoulder, sternal notch, and often it worsens after the surgery is what you need to remember. So, good to see around 6 online classmates. Can you please punch? Is the voice loud and clear for all of you? Is the voice loud and clear for all of you? Can you please punch? Who is all there online? Good. A 32-year-old female presents to the dermatology clinic with a raised red and itchy scar. The scar has been gradually increasing. It has become bothersome. It is firm, raised pink scar measuring 2 centimeters in diameter. So based on this description, a scar that developed 6 months ago. So what is your answer? Keloid. So mainly keloid versus hypertrophic scar, you need to know when does it develop, right? So that is the main differentiator. Hypertrophic scars are erythematous, but they remain within the boundaries of the original wound. They typically regress spontaneously over time. With appropriate treatment is what you need to remember. So what we will do is, good to see Sai and many more who are all online. Can you post it in all groups? Yeah. So now let us, what we do is, we'll take little theory and one next type of question, MCQ. That's how we will progress. Let's talk about abscess. Abscess anyway requires incision and drainage. And we give a cruciate incision. And at the site of the maximum point, we give cruciate incision. And what is that method called? Hilton's method. And what are the exceptions where abscess anywhere you need to it need to be well formed for you to drain. Exception is parotid, breast, axillary, thigh, and ischiorectal abscess are the exception. That absence only when fully formed before draining, these are the exceptions. So whenever there is a non-viscous cyst or ascites, then we use 6 to 10 French. If it is thick insippisated abscess, then we do saline irrigation with double lumen catheter is what we need to remember. Very nice to see Rajesh Reddy and all our comrades joining back. Wonderful to see 11 online classmates. Every day we are going to have a class. 150 days I'll be supporting you. Last 2 months, I had been thickly busy with clinical practice. Starting at 9 a.m. in the morning up to 9 p.m., there is a continuum of patients one after the other. Ultimately, clinical practice is also like teaching, right? So I see patients in Hyderabad, in Kukatpalli. I have a clinic called Idea Clinics. From morning 9 a.m. to evening 3 p.m. I see there. And 4 p.m. to 8 p.m. I see in TX hospitals in Banjara Hills, a 200-bedded hospital. So right now I am there in that hospital delivering the class, taking a break from the patients. I'm giving time to the doctors. So thanks for taking your time to join this session. Every day we will meet. Once more, we restart the game of doing the revision. एक दिन आएगा जब हम दुनिया को बताएंगे कि भाई हमने कामयाब हो गया, is what we need to tell the world. Good to see Anita Rani and many more, our old friends. Good. So what is antibioma? It is common in breast abscess, lot of fibrosis surrounding the abscess cavity. And what is cold abscess? No signs of acute inflammation, typically seen in TB. And how do you treat a cold abscess? We need to do non-dependent aspiration with anti-tubercular therapy. A lot of times, whenever there is an abscess and whenever there is a drainage, we place a drain. But very important rule in tuberculosis-associated cold abscess is drain is not placed in cold abscess because there's a very high risk of sinus formation is what you need to remember. So this is the typical Hilton's method with a cruciate incision for the drainage of the abscess is what you need to remember. Wonderful. हम बहुत खुश हो गया. 16 students online. Please do come, invite all your friends. Now comes the next topic, aortic rupture. What is the most common site for the aortic rupture? You know, ascending aorta, arch of aorta become descending aorta. It is the proximal part of the descending aorta where subclavian artery arises. That is the point where the aortic rupture most commonly happens, because this is the place where ligamentum arteriosum, there is a tethering of the aorta. So how do you classify aortic dissection? DeBakey has given a classification where if it is type 1, it involves ascending aorta, arch of aorta, and descending aorta. There is another classification called Stanford. It corresponds to the Stanford classification A. And whenever ascending aorta involves, the aortic valve involves, and that lead to severe aortic regurgitation, and that become fatal. And in all such cases, wherever ascending aorta is involved, what is the treatment, doctor? No more medical intervention. We need to do surgical intervention. Whereas in type 2, only ascending aorta is involved, and typically it also corresponds to Stanford A. Then the treatment, it is also fatal, because whenever ascending aorta involves, it is fatal. So that's the reason surgical. Whereas type 3, only descending aorta is involved, not the ascending aorta, right? So that is the reason here there is no need of doing any surgical intervention, only if the descending aorta is involved. And this corresponds to Stanford classification B. Treatment is usually medical. That is what you need to remember. And whenever aortoiliac disease, typically aortic bifurcation and common iliac arteries are also involved in dissection. So you need to be sure what is type A, type B in Stanford, and what is meant by type 1, type 2, and type 3 type. In the 3A, 3B. So what is the difference between 3A and 3B, doctor? 3A means suprarenal. Whenever it is involving infrarenal, then it becomes type 3B. Type 1 and 2, both of them involve the ascending aorta, is what you need to remember. So this is how at the point of the ligamentum teres is the most common location where the tear of the aorta, aortic arch rupture typically happen. This is an example of how a abdominal aortic rupture can occur. So what we do is we read a bit of theory. Already all this theory, high-yield facts, paragraph wise, is available in 1200 pages notes that I gave to you. If you did not get that notes, today only subscribe to it. We will do the courier to your home. All right. So 45-year-old male presents to emergency. So you need to know few concepts and high-yield facts. Then one corresponding next type of MCQ we will solve. That's how we will progress our subject. 45-year-old male, high-speed motor vehicle accident, severe chest and back pain, blood pressure is 90/60, heart rate is 120 beats, and there is a large pericardial effusion. And the patient is taken to the operating room, and there is a aortic rupture, which is confirmed. Now the question comes, what DeBakey classification does this basically correspond to? Do you have any guess? Do you like to tell possibly what is a DeBakey classification of this particular case? Just before now, we discussed it. So you should remember, DeBakey type 1 aortic rupture involve ascending aorta, and that extends into descending aorta. It is the most severe form. So type 1 rupture patients who are having ascending aortic involvement, they have a severe chest pain, back pain, signs of hypovolemia, evidence of cardiac tamponade, and they require urgent surgical intervention. DeBakey type 2 involves a tear of ascending aorta only without any extension to the descending aorta. So in this case, there is a severe chest and back pain. There is a hypotension. There's an aortic rupture involving both ascending and descending aorta. So that is the reason this is an example of what? DeBakey type 1 is the correct answer, is what you need to remember. Now comes the next very important question. Hyponatremia. All these things we earlier discussed, doctor. Everything is there in the SCORE app. 600 hours of video broken down into almost 14,000 5-minute short videos. Each paragraph is converted into video and already made available in the SCORE learning app. Today only subscribe. But the problem is having apps is not the way, not the only thing to get top rank. You should learn the subject, master the subject, practice whenever opportunity is there to see cases, and then solve as many questions as possible. That is the only way we will be clearing the next exam. If you are in Hyderabad, please come. Morning, I practice in Kukatpalli Clinic, 9 o'clock to afternoon 3 o'clock. I'll show you some wonderful cases. If you are in final year, please feel free to come forward. Evening, I practice in the TX hospitals in Banjara Hills, road number 12. You can come. I'll show you aortic dissections, hyponatremias, pyelonephritis, so many classical clinical cases. TX hospital is buzzing with the cases in Banjara Hills, road number 12. I'm the consultant physician over here, right? So you come and I'll show you the real-time cases also. So now, hyponatremia, how do you define it? Less than 135 milliequivalents per liter. So what do you mean by pseudo-hyponatremia? Whenever there is any hyperlipidemia, hyperproteinemia, osmolarity is normal, but typically the concentration of sodium in relation to lipid and proteins become diminished. So generally hyponatremia means low osmolarity, but pseudo-hyponatremia means normal osmolarity because of hyperlipidemia and hyperproteinemia. Then what is a cause of pseudo-hyponatremia with high osmolarity? Whenever there is any hyperglycemia, let us say patient is having diabetic ketoacidosis or is having a non-ketotic hyperglycemic hyperosmolar coma. In all these scenarios, osmolarity is high. So hyperglycemia, mannitol. And those people wrongly show hyponatremic values. That's called another example of pseudo-hyponatremia. So pseudo-hyponatremia with normal osmolarity is hyperlipidemia, hyperproteinemia. Pseudo-hyponatremia with high osmolarity is hyperglycemia and mannitol. Then what is meant by a true hypo-osmolar hyponatremia? Whenever hyponatremia is there, what do you expect? Osmolarity to be low, right? So then when hyponatremia is associated with hypo-osmolarity, you call it as a true hyponatremia. So once more, how do you divide the true hyponatremias? Look at their ECF. Conditions where ECF volume depletion is there, or conditions with normal ECF volume with hyponatremia, conditions with increased ECF volume with hyponatremia. That's how we differentiate. So whatever be the cause of hyponatremia, when true hyponatremia, how does a patient present? Patient presents with weakness, confusion, altered sensorium, nausea, vomiting, lethargy, anorexia. And whenever there is any, and that all leads to brain swelling. Whenever hyponatremia is there, cerebral edema, and that lead to development of altered sensorium. They also have drowsiness, convulsions, coma, death, etc., is what you need to remember. So this is one very important thing, doctor. Okay, sir, can the video can be made smaller? Definitely. Thanks for the feedback, Uzma, and please attend every day. See, doctor, 1 hour if you spend with me, I will give you the required motivation. There are so many learning apps, so many books, so many study materials today. But problem is what? To study, we need to have a timetable, a motivation, a classmate, a batchmate, a benchmate, a roommate to study together. So that is the need of the hour, right? So I am your classmate, tablemate, benchmate, every mate, and to help you to study every day. So in Score Learning app, we both have a web version and also app version. Both of them we will give you subscription. So you get 600 hours of video. All these notes which I am discussing now is already there along with the videos, right? 1200 pages spiral bound notes is there. I will also send it to you. I will courier it to you, right? Tell your friends also. So getting notes, getting app, subscribing, the job is not over. How do we consume it? How do we practice it? That is important. That is where you need Dr. Murli Bharadwaj every day, even from 9 a.m. to 10 p.m. I have a volley of patients, almost all 70 to 80 patients I see every day. But still, you are my priority. 1 hour I promise, in one of the part of the day, whether I sit in hospital or I sit in the home, anywhere, I'll spend 1 hour of my time to sir, please provide YouTube link directly through laptop. What does that mean? Acha, in the chat. Okay. All right. So in the WhatsApp group, be part of our WhatsApp group. We will send you the link every day, right? So you study, you listen every day. We'll study together every day, solve questions every day, and one day we will become the best when we go for the exam. Now watching through Android. Okay, good. So let's see. How do we approach hyponatremia? Whenever hyponatremia is there, look at the serum osmolarity. And how is the serum osmolarity? It can be high, it can be normal, it can be low. So whenever it is low, this is called true hyponatremia. True hyponatremia. A hypotonic hyponatremia. Whenever sodium is low, obviously osmolarity also should become low. Hypotonic hyponatremia. The other one is called normal osmolarity, but still hyponatremia. That's called isotonic hyponatremia. What is the cause? Any hyperproteinemia, hyperlipidemia, they all lead to isotonic hyponatremia. The other type is called hypertonic hyponatremia. So whenever patient has hyperglycemia, you have given radio contrast agent, mannitol, sorbitol, glycerol, maltose, all this will lead to hypertonic hyponatremia. So whenever hypotonic hyponatremia is there, look whether he is euvolemic, hypervolemic, or hypovolemic. If he is hypovolemic, hyponatremia is there, true hyponatremia is there, look why he is having hyponatremia. Suppose if the urine sodium is more than 20, then what is the cause? Diuretics, ACE inhibitors, nephropathy, splendocorticoid deficiency, cerebral sodium wasting syndrome, all of them will lead to diuretics, ACE inhibitors, nephropathies, mineralocorticoid deficiency, they all lead to urinary sodium more than 20 and land the patient in hypovolemic, hyponatremia, and urinary sodium more than 20. Otherwise, if urinary sodium is less than 10, that means kidney is not losing the sodium. Something else, diarrhea, vomiting, dehydration, they need to be looked into. In either of the conditions, whether kidney is losing, whether dehydration, diarrhea, vomiting, extrarenal causes are there, patient is hypovolemic. Then what lead to hypervolemic, hypotonic hyponatremia? Any heart failure, liver disease, nephrotic syndrome, advanced kidney disease, they're all edematous conditions. So he is hypervolemic. But euvolemic hyponatremia, which is hypotonic, think of hypothyroidism, SIADH, psychogenic polydipsia, then beer protomania, endurance exercise. All this lead to euvolemic hypotonic hyponatremia is what you need to remember. So how do we treat hyponatremia is a very important question. Whenever ECF volume is depleted, you try to give isotonic saline and also make them free fluid restriction. Whenever normal ECF volume is there, then you do fluid restriction. Increased ESF volume is there, like edematous conditions. Give diuretics, salt and fluid restriction. Also give tolvaptan, which is ADH antagonist. ADH antagonist is the one which is being given. And what is the rate of correction of hyponatremia? Less than 0.5 milliequivalents per liter per hour. Never more than 8 milliequivalents, never more than 8 milliequivalents per day is the benchmark. If you rapidly correct the hyponatremia, what is the complication? Central pontine myelinolysis is the complication of a rapid correction of hyponatremia is what you need to remember. So this is the treatment algorithm of the hyponatremia, which you need to be very sure about, doctor. Nice to see Dr. Meghaswana and many more who are all online. Now, let's take few questions. 60-year-old male, history of congestive heart failure, confusion, generalized weakness, serum sodium level is 118, serum osmolarity is 250, urine osmolarity is 500, urine sodium is 20. What is the cause of the patient's hyponatremia? So this is a case of hypovolemic hyponatremia. Hypovolemic hyponatremia. Because it has congestive heart failure, low serum sodium, low serum osmolarity, low urinary sodium, they're all consistent with hypovolemic hyponatremia is what you need to remember. So in this case, the kidneys are trying to retain water. It is causing a concentrated urine with low sodium content, that is urine sodium less than 30 milliequivalents per liter. Then why not it is syndrome of inappropriate ADH secretion. Here, the urinary sodium is more than 40 is an important part of definition of SADH. We will discuss about SADH down the line. Now, doctor, 35-year-old female with history of small cell lung carcinoma presents to the clinic with nausea, headache, generalized malaise, serum sodium 125, hyponatremia, serum osmolarity 20, urine osmolarity 600, urine sodium is 10. What is the likely cause of hyponatremia? So this is the kind of MCQs you need to expect in the tomorrow's NExT exam, doctor. NExT exam is completely clinical. All the questions are going to be clinical. So that's the reason you need to be sure how to attack the examiner. And I will give you all that required practice in our daily live class. So don't miss it. be part of it and join it. Now, what is the most likely cause? In this case, it is syndrome of inappropriate ADH secretion. But generally, urine sodium is more than 20 milliequivalents whenever there is any SADH, but here urine sodium is only 10. So is only 10. So that is the only thing that is not fitting. Otherwise, low serum osmolarity, high urine osmolarity, and hyponatremia, they're all fitting into the diagnosis of SADH very much. So you go to the score app, you type SIADH. You will get all the points, all the MCQs on SADH. You can always practice them on the score learning app. 45-year-old male, history of chronic alcohol abuse, disoriented, agitated, seizure in the emergency. There is a serum sodium of 120, serum osmolarity 270, urine osmolarity 600, urine sodium is 25. What is the likely cause? So this is an example of a beer protomania. Beer protomania. So typically, impaired water excretion, dilutional hypernatremia, concentrated urine with a high sodium content is the feature of SADH. So now, that is all the story about the hyponatremia. 2-3 questions about hyponatremia. Let's go to the next important area, doctor. Intermittent claudication. What is this? There's a cramp-like pain due to ischemia. Why it's called intermittent? There's a pain in the leg only on exercise. Most commonly in the calf region. And commonly it is the popliteofemoral incompetence is the underlying cause. Smoking, atherosclerosis, they're all the predisposing factors. And whenever you ask the patient to walk, whenever there is any peripheral arterial disease, in fact, you can reproduce the intermittent claudication. So, how do you differentiate lumbar disc compression, where there is a compression on the nerve leading to neurogenic claudication versus osteoarthritis? So, whenever the pain is precipitated by walking but does not occur on taking first step, then that is how you identify the vascular claudication. This is unlike what you see in osteoarthrosis. Whenever the pain is relieved by standing still, that is the pain of vascular claudication, unlike the lumbar disc compression where pain is not relieved by standing still. Then what is meant by Leritz's syndrome? Whenever the aortoiliac occlusion is there, then there is a claudication in gluteal area along with impotence, which is called Leritz's syndrome. And lumbar sympathectomy is contraindicated in case of the Leritz's syndrome is what you need to, whenever there is any vascular claudication is what you need to remember. Now comes the next important topic, hypernatremia. So how do you define hypernatremia? Whenever the plasma sodium is more than 145, hypernatremia. And hypernatremia can occur because of too much loss of water, severe burn, severe exercise, diabetes insipidus, excessive diuretics, heat exposure, uncontrolled diabetes mellitus, osmotic diarrhea, etc., etc. Then, typical rule, fluid retention is synonymous with hyponatremia. Dehydration is synonymous with hypernatremia. That means to treat hypernatremia, what do you need to give? you need to pump the solute-free water, solute-free water. So you need to calculate how much water you need to push. Whereas in hyponatremia, you need to calculate how much sodium you need to push. That's the main point you need to remember. So once more, hypernatremia is also divided into hypovolemic, euvolemic, hypervolemic. Once more, based upon the urinary sodium, more than 20, less than 20, more than 20, less than 20. There are the various causes which you need to know when approaching the problem of hypernatremia. So fundamentally, in hypernatremia, you need to calculate the free water deficit. You need to give this fluid in 48 to 72 hours. And whenever there is an acute hypernatremia, it is the 5% dextrose which you choose. Whenever there is a hypernatremia with contraction of the extracellular fluid, then isotonic saline followed by 5% dextrose. So whenever central diabetes insipidus is making you to makes the ADH completely useless, then vasopressin is the treatment. If it is the nephrogenic diabetes insipidus, we treat thiazide. Whenever nephrogenic diabetes insipidus is causing hypernatremia, we give thiazide. Whenever lithium-induced hypernatremia, then we treat with amiloride. So these are the important points you need to remember when it comes to hypernatremia. Now, doctor, a 68-year-old female with a history of diabetes admitted with the altered mental states. There is hypernatremia. Osmolarity is 310. Urine osmolarity is 150. Urine sodium is 20. What is the most likely cause? So this is the algorithm you need to become sure in your funda. Whenever hypernatremia is there, look for hypovolemia, euvolemia, hypervolemia. Based on urinary sodium high, urinary sodium less, you try to remember the causes. That's how you approach the clinical problem. So it's a case of central diabetes insipidus. So how did we reach that conclusion? So whenever there is any deficiency of ADH, there's impaired water reabsorption in the renal tubules, leading to excessive dilute urine, increased thirst, and hypernatremia. So why not it is nephrogenic diabetes insipidus? Typically, if it is a nephrogenic diabetes insipidus, the urine osmolarity is more than 300 because of the impaired response of kidneys to ADH. So whenever, why not it is hypovolemic hyponatremia caused by water loss, there the urine osmolarity will be more than 500 because kidneys attempt to conserve the water. And so that's how you need to approach and finally boil down to the answer of central diabetes insipidus in this given clinical scenario. So a 42-year-old male, history of chronic kidney disease, comes with confusion, decreased urine output. There is serum sodium level of 165. Patient's serum osmolarity is 320 milliosmoles per kg. Urine osmolarity is 600. Urine sodium is 60 only. What is the cause of the patient's hypernatremia? So it's a renal failure, which is the underlying cause in this given case. So how do you reach a conclusion? So basically, all the remaining can be ruled out based upon the urine sodium. Once more, you need to be sure on this table. What is the causes where urine sodium is less than 20 versus more than 20 in a hypovolemic, euvolemic, hypervolemic? Based upon that, you need to reach out to the answer. So now, a 26-year-old female, unconscious, febrile, tachycardic, serum sodium high, serum osmolarity 300, urine osmolarity 400, urine sodium is 40, increased. So what is the cause? It is a hypernatremic dehydration, which is the underlying cause, is what you need to remember. I leave these questions and explanatory answers in a PDF for you for practice. But most important, you need to go back. You need to go back and do the revision on the Score Learning app any day in order to get a hold on the subject. So there are two components, doctor. One is to know the high yield facts, high yield topics, funda, and practice the clinical vignette based USMLE styled NExT exam styled MCQs. When only you combine these two, you become the winner. So thank you very much for joining this session. Patients are waiting, and I'll once more, every day milenge, milke padai karenge, be part of the WhatsApp study group. Thank you.